My name's Timothy Beaty. I'm a pediatric pulmonologist here with HPH Medical Group and clinical assistant professor at University of Hawaii. My background is I did my residency at Tulane in New Orleans and fellowship at Emory University in Atlanta, Georgia. And then I was faculty there for 3 years. And came to here in October 2020. The presentation today is about the updates in asthma clinical care guidelines from the NHLBI, which were released in late 2020, but we're still trickling the information out there. This is not a complete overhaul of the guidelines. It was specific issues that needed to be updated with two primary clinical things to be addressed, which one of which I think will be very helpful for you guys. So if we could just move on. I have no financial interest for anything to do with this material. There is discussion of off-label use of medications because the guidelines themselves have off-label use of medications in them. Okay, so our learning objectives for today are to go over the 2020 NHLBI updated guidelines for asthma, in particular the two topics of the evidence and best practices for intermittent inhaled corticosteroid in children and for SMART therapy. I have a lot of slides. We're going to have to go quickly through a lot of where I talk about the studies these recommendations are based on, but I wanted them in there so you guys could see them and maybe look them up later and read the study if you want to. Next, here's our first case. Too far. We've got a 3-year-old who's come to you to establish care after moving to the islands from Vermont. His mother states, "I just want him checked out before preschool starts in August." He does have a history of albuterol and steroid-responsive wheezing with upper respiratory infections, and he did have an exacerbation requiring a steroid burst in the last 12 months. In between his URIs, he has no cough during the day or the night, does not seem to have an albuterol requirement outside of illness, and he has no symptoms with active play or exercise. And she tells you, "Our last doctor gave us albuterol and another inhaler to use as needed for respiratory infections. Can you do that too?" So here we have the classification for asthma impairment and risk. If you just click through for this patient, he's 0 to 4 years old. So he's having no persistent symptoms, too young to do lung functions, and 1 steroid burst last year. Recommended step therapy would be step 1. Go on to the next slide. So here's what they looked like prior to 2020 update. Step 1 in a patient of this age would be a short-acting beta agonist as needed. So albuterol as needed for coughing or wheezing. In the updated guidelines, step 1, the preferred treatment is actually as needed short-acting beta agonist and at the start of respiratory tract infection at a short course of daily inhaled corticosteroid. And notice that this is the preferred treatment. They're not listing it as an alternative option. They feel like the evidence for benefit with this therapy outweighs any potential risk of starting a short round of inhaled corticosteroids. So I wanted to talk about what evidence they're basing that guideline on. Keep moving. This is from the physician handout that came along with these guidelines. That scheduled daily inhaled corticosteroid is still the preferred controller therapy for patients with persistent asthma. So patients who have ongoing wheezing outside of illness, coughing that you suspect is due to bronchospasm, you would still recommend an everyday controller therapy for them. However, in young children, 0 to 4 years old, who have wheezing associated viral infections and no signs of persistent symptoms in between, they recommend intermittent inhaled corticosteroid. Recurrent wheeze in these guidelines are defined as 3 episodes in their life or 2 in the last 12 months. The first article I was going to go through was published in 2009 in New England Journal of Medicine. It was by Ducharme, titled Preemptive Use of High-Dose Fluticasone for Virus-Induced Wheezing in Young Children. This patient population they were trying to get non-atopic or non-allergic children with purely viral-induced wheezing by history. They chose young children 1 to 6 years old, who had had 3 episodes of wheezing-associated respiratory infection, no symptoms in between, and at least 1 steroid burst in the last 12 months. This is not for your severe patients. So if they have a prior intubation for respiratory illness, if they have neonatal respiratory illness or disease, including prematurity, so sort of a low risk, persistent wheezer, and importantly, non-allergic. What the parents were told is that the first sign of respiratory tract infection, so anything the parents see, whether it's runny nose, whether they complain of a sore throat, if they get an earache, they're to go ahead and start the fluticasone, but at a very high dose. So the high dose fluticasone or Flovent in the United States is 440 micrograms BID. So that's the 220 inhaler, 2 puffs morning and night. So they're doing almost twice that in this study. You continue that until 48 hours past the resolution of their symptoms. They can go ahead and use their albuterol as needed for lower respiratory tract symptoms of cough, wheeze, and just keep clicking through these. They did measure potential side effects of high-dose inhaled corticosteroid, bone density, bone age, serum cortisols, height, and the patients were withdrawn from the study if they had frequent use of therapy, like they were on their Flovent almost more than half the time for 3 months, if there was a perceived lack of efficacy or poor control, or if they had a severe exacerbation with an ICU admission. What they found is that in the fluticasone group, there was a reduction in systemic steroid use with an odds ratio of about half. In their secondary outcomes, they did see statistically significant differences in the duration of upper respiratory tract symptoms, duration of albuterol use, and quality of life symptom scores. There was a trend, but non-significant, for how many upper respiratory tract infections these patients reported during the year-long study, admissions to the hospital, and acute care visits. There were only 2 ICU admissions, and both of those were in the placebo group. So children who were on a placebo inhaler during upper respiratory tract infections, but they could use their albuterol for symptoms. No ICU admissions in the treatment group. Further safety information, this study did show, if you click through, I circled the height measurement, in particular the Z-score. So they actually did find that there was a decreased height velocity in the treated group as compared to placebo group. And as you know, this is something that has frequently been seen in studies on fluticasone in particular. It does seem to, especially when you start it, it does seem to decrease height velocity. Typically, those children do catch up over time. However, this is a very high dose of fluticasone. The take home from this study is that a very high dose of fluticasone at the onset of upper respiratory infection compared to albuterol alone resulted in fewer systemic steroid bursts over 1 year and shorter duration of symptoms, but potentially a small effect on reduced height in the treatment group. They also saw a reduced weight in those children which is not something that we typically see with Flovent. They didn't spot any differences in bone mineral density or bone age. The study did not show a minimum or optimum dose to achieve the desired effect. So we don't know if you actually need a dose of Flovent that high. And importantly, this excluded our patients who are atopic. They did find that 7% of the enrolled children actually developed allergic rhinitis through the time of the study, but it's considered that they did not skew the study results all that much. This also doesn't include our patients who have had severe exacerbations in the past. If you've had a patient wind up in the ICU, even if they have no persistent symptoms, this might not be the right therapy for them. Second trial that this was based on is from 2011, also in the New England Journal of Medicine, daily or intermittent budesonide in preschool children with recurrent wheezing. Now, the study population of this study is a bit different. So 12 to 53 months, but these researchers were actually trying to get those atopic patients with a positive asthma predictive index, which means allergic rhinitis, potentially positive skin testing or IgE to specific aeroallergens, family history of asthma, for instance. So first study, trying to focus solely on non-allergic wheezers. This study is preferentially sampling those allergic wheezers. Enrollment criteria are they've had 4 episodes of wheezing or 3 episodes and controller use for 3 months in the last year. So 3 episodes of wheezing and somebody prescribed Flovent for them. At least 1 steroid burst in the last year. However, if they have severe disease again, so more than 6 rounds of steroids or 2 hospitalizations in the prior year, we are not looking at those children. Here's their trial design. The patients who were on daily therapy were on budesonide 0.5 milligrams just once a day, and they had a placebo nebulization added on during respiratory tract illness. The children who were on treatment group were on placebo daily, and then during respiratory tract illnesses, they started up, again, very high dose of budesonide, 1 milligram morning and night. The researchers made sure to point out that the reason budesonide was chosen is that for the majority of these patients, that's the only FDA-approved inhaled corticosteroid in this age group. And here are their studies. It was a non-inferiority study. So in the bar graphs, the treated group are the orange bars, and the placebo group, daily budesonide group are the blue bars. And what they found is that there was really no difference between the treatments as far as how many rounds of prednisolone they got throughout the year. Time to first exacerbation, frequency of treatments for respiratory illness, or first time to treatment for respiratory tract illness. In their safety monitoring, they do note that the primary benefit of intermittent budesonide in this group was that despite when they're on budesonide, they're getting 4 times as much, their overall budesonide treatment level throughout the course of the year was about 1/3 of what the children getting daily budesonide were, and they achieved similar clinical results. So 1/3 of the steroid exposure with similar outcomes. There was no difference in hospitalizations, height, weight, or head circumference in this study. So one caveat to this is that the parents in this trial had a very good history taken and were taught in excruciating detail when to start their budesonide. And if we'll go to the next slide, can see the forms that they used. And so the parents were really given this huge list of symptoms on the right, and were asked, what is the first symptom you notice that makes you believe they're going on to a respiratory illness? And then if there are more, you continue going on. And so the parents were really focused in on specific symptoms that in the past had led to their children wheezing. And this might not be something that's reproducible in our clinics, just from a time standpoint. But the take home from this study is that high-dose intermittent budesonide may be just as effective as a daily low-dose budesonide to prevent systemic steroid bursts. They do note that because of their wide confidence interval, there is a possibility that with a stronger study, one treatment strategy over another may actually turn out to be more beneficial. This may not be generalizable to children who have more severe exacerbations, or maybe even more mild patients, and who have, for instance, frequent wheezing but don't get steroid bursts throughout the course of a year. And then careful history taking and careful caregiver education was required to achieve these results, which is probably a big ask in our pediatric clinics. But taken together, the expert panel felt that the benefits of short courses of inhaled corticosteroids at the time of respiratory illness outweighs these risks of possible delayed growth in height, or the steroid exposure during every single illness when they might not have gotten any steroids by mouth. And so they're now recommending budesonide 1 milligram inhaled BID with an asterisk or equivalent inhaled corticosteroid, so not taking Flovent off the table, for 7 to 10 days as needed at the onset of respiratory illness. The primary benefit being the reduction in need for systemic steroids for an exacerbation. A secondary benefit that caregivers can initiate this in the home as soon as they recognize those symptoms, and may not even need a visit to a healthcare provider to initiate treatment for their wheezing. They do recommend that you discuss with the caregivers how to use their asthma action plan if you're instituting this, and potential risk of reduction in height velocity, particularly if you're using the high-dose Flovent regimen. Other benefits, parents anecdotally love this. They don't like giving a patient an everyday medicine if they're not having any symptoms. They like, when my child gets ill, this is the medicine I use to prevent it from worsening. It seems like you're getting similar control as far as preventing exacerbations with much less overall steroid exposure. Reduced cost of therapy, so they're not having to refill their inhalers every month. In fact, a lot of families are not even having to replace their controller therapy more than once or twice a year. And treatment can be directed from home without having to come in for a physician evaluation. My child has a runny nose, I'm starting up their Flovent to prevent it from going down to the chest. And that's all I've got on intermittent inhaled corticosteroid. I'm happy to open this up to questions if anybody has any on those recommendations.
Nothing in the chat yet, but we'll definitely let you know at the end. And if things come to mind for our audience, just put them in the chat and we'll run through the list also. So no worries. Generally people are pretty shy, but they do open up toward the end when there's the chat and question time.
Okay, perfect. So this is the second case I came up. This is another typical scenario I get. We have a 14-year-old male with atopic asthma who's coming in for follow-up. The mom has a disappointed look on her face. She says he actually stopped taking his Advair 6 weeks ago, but she's noticed he's using his albuterol almost every day. And he says this is because his chest feels tight. He says that he stopped taking it because he lost his Advair and just forgot to tell her. And besides, it doesn't do anything when I take the albuterol. It actually helps. His mother says, well, I'm not going to be the one in trouble if you wind up in the hospital again. This might be a patient where you could consider single maintenance and reliever therapy. So what are the SMART recommendations? So this would be for children down to the age of 4. And the reasoning behind this is that polypharmacy, as you know, is an issue in asthma. Patients are frequently confused. What is their controller? What is their reliever therapy? Is it really important to stay on my controller even when I don't feel sick? And so the idea behind this is, can we achieve similar results with a single inhaler? So potential benefits include treatment regimen simplification. I have one inhaler. I take it every day. When I feel sick, I take it more often to relieve the illness. Decreases patient confusion. And if you have the anti-inflammatory in that inhaler along with a bronchodilator, you're actually increasing their dose of inhaled steroid at the time when they need it more often, when they're having more of that inflammation in the airways. And preferentially, this will, or theoretically, this would decrease their need for reliever therapies as you up the anti-inflammatory. This treatment regimen is dependent on using formoterol as the long-acting beta agonist, as it has a more rapid onset of action than salmeterol and a longer duration of the bronchodilation compared to albuterol. I've experienced this myself, so I've tried Advair and Symbicort. I don't have asthma, but just try it. And you can feel Symbicort hit you harder, or at least I did, and patients report that as well. The first trial that included younger kids was from Rabe and Chest, 2006, called budesonide and formoterol in single inhaler for maintenance and relief in mild to moderate asthma. This study included children and adults down to the age of 12 with sort of moderate disease, FEV1 down to 60%. They are patients who are dependent on their as-needed inhaler, so symptoms 7 out of the prior 10 days, although they're not using it throughout the day, so less than 10 PRN treatments on any given day. They were excluded if they're an asthma patient who's on daily systemic corticosteroids, if they were using something like cromolyn, if they had cardiac disease or were smokers, trying to get out some of these COPD patients. Their intervention was patients were started on low-dose Flovent, so low-dose Symbicort, 80 micrograms, 2 puffs once a day. And then as they felt symptoms, they were instructed to take more doses of their Symbicort up to a maximum of 10 per day. 12 inhalations per day, which means 10 PRN treatments per day. And the control group were on budesonide 160 micrograms nightly, and they were using terbutaline for symptom. This study, because they included patients up to the age of 80, the average age of patients in the study are out of the age range of most of our clinics at 38 years old, but there were patients down to 12. I could not find, even in the appendix, how many pediatric patients there actually were in this study. Their primary outcome did find that the overall exacerbation rate in the treated group was reduced by about half, 43 versus 94 in the control group. And they had about a fifth of the number of days on systemic steroids. They had less severe exacerbations and less hospitalizations in the SMART therapy group. Asthma symptom scores were also better in the SMART therapy group. And as predicted, the patients who were on SMART therapy actually took less doses of their reliever than the patients who were not on SMART therapy. Adverse events were similar in the two groups, and serious adverse events were actually lower in the SMART therapy group. Second study, also published in 2006. This is more the pediatric age group, so children aged 4 to 11 years old who've been treated for asthma for more than 6 months, more than one or more exacerbation in the last year, and they've been on a consistent dose of inhaled corticosteroids for the last 3 months and are frequently requiring short-acting beta agonists for symptoms. So children who've been on a stable dose of asthma therapy for the last 3 months who were still symptomatic regularly. There are 3 treatment arms in this study. So they had the SMART treatment arm was low-dose Symbicort, so 80 micrograms, 1 puff a day with 7 as-needed inhalations per day. The combo group, which is basically what the standard therapy would be, combined ICS/LABA with low-dose budesonide, who were using terbutaline as needed for symptoms, or the inhaled corticosteroid group only, who were on a higher dose of budesonide daily and terbutaline for symptoms. Here's this patient population. Average age about 8, mostly Caucasians. Everything else is fairly similar. What they found is that the SMART therapy group did have a significant reduced relative rate of exacerbations. You can see this. Actually, I don't have this graph here, but they had a marked reduced in the number of days they were on oral steroids throughout the study period. And they did have decreased nocturnal awakenings, no difference in asthma-free days. You can see on the right, they have this curve of patients who had a severe exacerbation, with the dark line being the patients on SMART therapy, much lower than either the patients on combined ICS/LABA or just the ICS alone. And then below that, the rates of all exacerbations, peak expiratory flow rate falls, extra treatments of their reliever therapy or hospitalizations, with benefits in the SMART therapy group for all of them. Patients on SMART therapy trended to have lower as needed drug doses, but it did not reach statistical significance. There were actually, in the SMART therapy group, there were only 6 who got to that maximum of 7 as needed treatments in a day, as compared to 23% and 15% in the other groups. And then they wanted to look at what is their total inhaled corticosteroid dosage to make sure that people aren't getting exceedingly high doses of the inhaled corticosteroid as they're frequently taken the as needed doses. And they found that they actually, most of the children actually had ranges below that 160 micrograms per day, which is the high dose Symbicort range. They didn't see any difference in height growth between these patients. They're all on inhaled corticosteroids, which might explain some of that. There were no significant serious adverse events. So the take home from this study is that among young patients with uncontrolled persistent asthma who were already on inhaled corticosteroids, SMART therapy may lead to reduced exacerbations, compared to adding just the LABA or increasing the inhaled corticosteroid dose. Seems to be well tolerated in these patients, and these patients didn't seem to be having excessively high exposures to either inhaled corticosteroids or systemic burst, and but they weren't actually seeing improved asthma scores. The benefit is those reductions in the exacerbations. They're just anecdotally, there's a pediatric pulmonologist in Canada who frequently reports on his experience with SMART therapy from over 10 years. He says that the primary benefit really is that that simplification of the treatment regimen actually helps a lot of his patients to not be overwhelmed by how many therapies I'm getting. So in summary, for those children 12 years of age and older, there are now 2 studies with over 3,000 patients who found a SMART therapy reduces exacerbation and with no increased risk found. They labeled the certainty of evidence high. And in the younger children, less than 12 years old, certainty of evidence moderate. This is only about 200 children. They don't seem to be at increased risk in a 1-year follow-up. And they, in that one study, did have a significant decrease in risk of exacerbation. So here are the updated step therapy. This is the younger children, age 5 to 11 years old. They've listed the preferred treatment option for step 3 and step 4 is daily and as needed low dose ICS with formoterol. So again, not Advair. This is Symbicort specific, potentially Dulera. And then this is the older kid, so 12 years of age and older. Again, preferred therapy, the same as we just discussed. I've taken this from the physician quick reference for these recommendations. Target population, 4 years and older, who've had a severe exacerbation in the prior year and who are uncontrolled on the standard asthma therapy you've been giving them. If they're 4 to 11 years old, start them on sorry for the misspelling, start them on Symbicort, 1 puff daily at a low dose or 2 puffs daily at a medium dose, and they continue to use their same inhaler up to 8 puffs a day for PRN use. And then the dosages, low and medium and max puffs, are a bit higher for the 12-year-old kids. There are some issues with SMART therapy, things that I don't know the answer to necessarily. So what do we do if they're reaching their maximum puffs per day and they're still symptomatic? Do you say go ahead and use albuterol, in which case you're they also have to deal with the second inhaler? Is the albuterol going to work if all their beta receptors are already saturated with the formoterol that you've been giving them? Patients who have a higher maintenance dose actually have less PRN doses available to them. So if you have a patient on 4 puffs of their formoterol per day and they're doing 2 puffs with a PRN, they've only got 4 PRNs available to them. Is this going to lead to tachyphylaxis or downregulation of the beta receptors over time? That has been seen in long-acting beta agonist studies in the past. Did not seem to be evident in these studies. And I haven't, for people using SMART therapy, they haven't, this hasn't seemed to be an issue, but as a theoretical risk. There were some patients who were taking their maximum puffs per day, and you can imagine that you might have an outlier patient who's taking their maximum amount of puffs every day. Are these children going to run into issues with either the exposure to their inhaled corticosteroid or the long-acting beta agonist part? And then just formulary issues here in America, at least, insurance companies and Medicaid are still not on board with filling somebody's controller therapy more than once a month. Whereas if you have a patient who has one inhaler and they're taking 12 puffs a day for 7 days, they're going to run out of their inhaler before a month. And so I do know that HMSA, for instance, are thinking about how can we accommodate these patients on smart therapy, but I don't know if anywhere in the States where this is routinely being used for this reason. Are your patients going to run out of their controller and then they're off controller for a week or two? So just a summary of what we talked about today. So intermittent inhaled corticosteroid, this is a major clinical change from what the recommendations had been from before 2020. There actually is a role for intermittent inhaled corticosteroids. That role is in very young kids, 0 to 4 years old, who are recurrent wheezers and do not have persistent symptoms outside of respiratory tract infection. Dosing is still a little bit up in the air. It might be possible to treat these patients with lower doses of inhaled corticosteroid for similar benefit. However, the recommendations are currently 1 milligram budesonide twice a day for 7 to 10 days, asterisk, or equivalent. With the smart therapy, consistently it has shown that this is beneficial, at least for reducing exacerbations. However, this is not ready for prime time in America due to primarily unanswered questions that I have regarding these frequent users, as well as these patients are not going to be able to refill their inhaler if they're using their controller therapy frequently for as needed symptoms. We should be hearing more about this as those problems are worked through. All right, so we've got our questions again. Most appropriate use of intermittent inhaled corticosteroid is?
Oh, don't leave the answer quite yet.
Yep, don't click through.
I won't click through. I'll give everyone 30 seconds or so to put in their answers. And then there's one question so far in the chat. So after you've put in your answers for the poll, go ahead and you can start putting your questions in the chat and we can start working through those, or even just a discussion point. Those are always great start-offs too. Some answers, let's see. All right, we'll give everyone about 20 more seconds and then we'll go through the answers. Anna looks like she's contemplating.
I'm always contemplating.
Study.
I'm so bad at multiple choice. No matter how convinced I am, I know the answer. I just always get thrown by options. Thankfully, real life medicine is not multiple choice. Or all the multiple choice, I guess, depending on how you want to see that.
Yeah. Okay, I'm gonna go ahead and close the poll and I'll we can go through the answers.
All right. So there's still some issues here. This may hinge on the word severe. So what are we using for a definition of a severe exacerbation? I'm using ICU admission for this question. So the reason I put D as the preferred answer is because this is for patients aged 0 to 4 years old with who have recurrent wheezing and can get a systemic steroid burst. And as I was writing the question, the intention was this is as an outpatient, not a patient who's been admitted multiple times. The studies that this treatment is based on excluded patients with severe exacerbations in the past. So that's why C is not correct. For question 2, so the recommended regimen is budesonide 1 milligram twice a day. So remember the budesonide brand name Pulmicort comes in 0.25 or 0.5 milligram vials. So typically you guys are writing 0.25 or 0.5 milligrams twice a day. When you're using it in an intermittent method, it's actually 2 of those vials morning and night, which is much higher dose. The benefit is they're not on it daily. Somebody put medium dose Flovent. This may be because you've seen some of us do that in the past. So I'll admit for many of the patients, I'm actually writing medium dose Flovent, and anecdotally, there does seem to be some benefit with it to prevent the severity of their exacerbations. There's leeway in doing that because what the recommendations are is the 1 milligram budesonide twice a day or equivalent. So the fluticasone dose that was tested is actually very high, 720 micrograms twice a day. But typically what I do is either the standard high dose, so 440 micrograms twice a day, or medium dose, the 220 micrograms, which is what's here. The primary reason why I would do that is because I'm trying to switch patients over to their inhaler with a spacer as a time saver, basically. If children are already on nebulized medicine and that's all they've done, and they're never used an inhaler in the past, and it seems like they're on the cusp of outgrowing this, which often by the time they get to me, they are, I will just write that budesonide at 1 milligram twice a day during illness, and then get them through the cold and flu season. And then by next cold and flu season, typically I'm saying no need to continue this. And then for question 3, the B is not right because by payer, I meant the insurance companies and the pharmacy safety net as well. Patients are going to be allowed to go in and get 2 or 3 inhalers of Symbicort per month currently still. And so it's parents might prefer 1 inhaler and patients might prefer 1 inhaler. It's the payer side we're having an issue with.
I feel that answer can be correct for most conditions and most specialties, unfortunately.
Gotcha. Yeah.
Well, thank you so much for going through your answers in so much detail as well, especially with those trick questions we got.
I honestly did not intend for there to be any trick questions.
No, not at all.
Yeah,
so we did have a question of whether you would suggest that parents are reporting their use of intermittent steroids on arrival in the office.
Oh, on arrival in the office.
Or I'm assuming or usage to your office. Maybe Dr. Ray can clarify. In general to your office. In my head, I almost would, in an ideal world, love to know anytime my patients are taking it, just to be able to keep a little bit track of that. But I don't know how you've been suggesting it.
Mm-hmm. So yeah, great question. I don't. I always ask when they come back to their follow-up, how many exacerbations did you have since the last visit? Partly because partly that's because for these patients, typically I'm able to see them every 3 months. And so I probably have more frequent follow-up than you guys. At the doses I'm prescribing, so medium or high dose Flovent for the most part, these are, I consider them very safe medicines. So even if or let me put it in another way, there are other children of the same age and same height who I would say you need to take your high dose Flovent for the next every day for the next 3 months until you see me again. And side effects are possible, but pretty rare, and you can deal with them. So if the patient is, even if they're starting their Flovent once or twice every month, by the time they get back to me, it's still not a real concerning high dose of exposure to inhaled corticosteroids. Does that answer the question? Even if they're getting some breaks off of the Flovent, they're getting even less dose than somebody that patient who's on it for a controller therapy, and I'm not all that worried about their side effects for the most part.
And did you see those kiddos that that are more severely ill that you follow, since you do have the potential of seeing them more regularly? Do you recommend that providers, I don't know, have their kiddos that they know are kind of going to be on and off, maybe just follow up with them more frequently, especially during the winter months when we're expecting peaks? Okay.
Yep. That's the key. So these things are seasonal. Although, I'm new to Hawaii. I don't know how seasonal it is here when it's non-pandemic times. But yeah, I think
it's variable, I would say, even before pandemic times. But we do get a bit of seasons. They're just not quite as neatly tucked away.
Yeah.
Although you do bring up a good point, and it really is a good question. Not just this year, but even for coming years, what our seasonal is even going to look like as these kids are all kind of catching up with their virus exposures. Does anyone else have any other questions? Any cases that you would like to just run by the team or the whole group, since we have everyone on? If not, everyone else gets an extra 5-minute lunch break today, which I'm sure no one will complain about. I'm so glad that we have this talk again. I think it was really perfect timing as kids are starting to get sick more and more often, and especially as these respiratory bugs are going around that we're just seeing so frequently. Oh, Dr. Vega, you have a question. Would you like to unmute yourself and ask away?
Yeah, if Tim, if you could briefly tell us a little of historical context here. I mean, looks like these recommendations have been changing all the time and back and forth. I mean, steroids in particular, sometimes they were preferred, then they were demonized, and it looks like they're back again. I mean, do you think this is right? Is premature? Do you see this going the same way? Is it that we have better products now and that's why we feel more comfortable? I mean, can you give us a little of overall perspective where this is coming from and where this is going?
So you mean specifically to inhaled corticosteroid?
Yeah. I mean, again, yes.
So I came up in the era of these inhaled corticosteroids are actually very effective and safe. You can detect occasional cases of adrenal suppression and changes in height growth, even in people on medium dose inhaled corticosteroid in the appropriate setting. So typically when these are reported, these are children who aren't just on their inhaled corticosteroid, but they're also receiving steroids for other reasons, even if it's just fluticasone, Nasonex, or Flonase because they frequently have allergies. They get systemic steroid burst intermittently for asthma exacerbations. So, you know, in general, the current recommendations, I think, are based on very good data that these are efficacious in preventing hospitalization, symptomatic exacerbations requiring systemic steroids. Over and over again, the exposure to steroids overall are reduced in children with persistent asthma on a daily controller as compared to reliant on steroid burst at the time of symptoms. So as with any medicine, there are risks. And so what I tell parents that fluticasone, in particular, high dose fluticasone, so 440 micrograms morning and night, has been shown to reduce not just height velocity, but in young females, if on them for on average 3 years, it can actually reduce their final adult height by a centimeter. But for those patients, because they're staying out of the ER, staying out of staying off of systemic steroids, their overall steroid exposure is expected to be much less on these medicines than off. And in addition, part of the guidelines are to drive down their daily dose of inhaled steroids to the lowest amount possible that's going to keep them under control. And the way that the guidelines would say do that is you have to evaluate them every 3 months and see if you can decrease their dose, right? I have the flexibility, since I'm a specialist, I am seeing my patients about every 3 months. Every time I see them, I try to get them on a lower dose if I can. And for my patients, I can tell them, hey, we're starting this medicine. It's going to be daily. There are potential risks. We feel like the benefits vastly outweigh the risk. And in addition, if we can get you on lower doses or off these medicines, I will do it. But I'm going to do that over the next 3 to 6 months, not over the next week or so. Does that answer the question? I understand that might be different in peds clinics because you guys see so many patients, you might not be able to get them in every 3 months and drive that controller down. But when you do see them, you should be actively trying to get them on less daily doses if you can.
Thank you so much. And you managed it in perfect timing for 1 p.m. I'm seeing lots of thank yous into the chat. So yes, thank you again for joining us for a second time now, or almost third, I think. We're always happy to have you back. Our next